Welcome everyone to today's webinar, How to Handle the Unique Revenue Cycle Challenges Affecting Children's Hospitals. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, I am pleased to introduce our speakers, Judson Ivey and Matthew Love. Judson Ivey founded Ensemble Health Partners in 2014 after spending almost 15 years as a revenue cycle executive in large hospital corporations. Judson's belief in loving what you do, providing excellent service, and caring about your team are what are at the core of the Ensemble Health Partners philosophy. Judson has extensive operational experience in helping providers maximize their revenue cycle operations, in addition to his ability to drive innovation within revenue cycle. As Vice President of Revenue Cycle at Health Management Associates, he was responsible for regional service center operations, patient access services, health information management, and revenue integrity and analytics. Judson held multiple related positions with community health systems, including Director of Patient Financial Services, Regional Patient Financial Services Director, and Vice President, Regional Service Center. As Vice President at Community Health Systems, he was responsible for establishing a new regional service center and received multiple internal awards for his accomplishments. He is the co-author of Cataract Surgery for the Revenue Cycle and a member of HFMA and the American College of Healthcare Executives. Matthew Love serves as President and CEO of Mcos Children's Health System, the region's only healthcare system exclusively for children and the parent organization of Mcos Children's Hospital, a nationally recognized nonprofit pediatric specialty hospital based in Miami, Florida. In his role, Mr. Love oversees the 309-bed Mcos Children's Hospital and its network of pediatric outpatient centers situated in Miami-Dade, Broward, Martin, and Palm Beach counties, along with other health system entities, including Mcos Children's Pediatric Specialists, a nonprofit physician practice subsidiary, an ambulatory surgery center, and Mcos Children's Hospital Foundation, the organization's 501c3 fundraising arm. Mr. Love has more than 25 years of experience in financial and operational leadership in both adult and pediatric healthcare systems. Most recently, he served as Senior Vice President and Chief Financial Officer at Regions for Mercy Health System in Ohio, where he led a team of 7 regional CFOs. Prior to Mercy Health, Mr. Love served in operational and planning roles for several years at Children's Hospital in Memphis, Tennessee. He is a fellow in the American College of Healthcare Executives. He is a graduate of Ohio State University, where he earned a bachelor's degree in industrial and systems engineering and has a master's degree in business administration from Cleveland State University. At this time, I'm pleased to turn the floor over to Judson to begin today's presentation.
Thank you very much, and good afternoon, everyone. And I'm very excited to be here with you today and with my good friend Matt Love from Mcos Children's. Today, we maybe take a look at the agenda on the screen here, and we really intend for this to be a conversation versus a kind of death by PowerPoint. But some of the things that we hope to cover today are the unique challenges of children's hospitals and the pre-COVID-19 challenges. What the current environment is of children's hospitals, how we've been able to combat some of the disruptors, challenging the status quo for children's hospitals, and ultimately improving the revenue cycle that aligns with the mission of children's hospitals. A little bit about Ensemble as we start our call today. We have more than almost 7,000 team members that are working for the benefit of our partners. We have 18 end-to-end, we refer to end-to-end all the way from the beginning of patient encounter to essentially zero balance, in which we have 18 full outsourced customers or partners. We're working with over 7,000 providers, 410 individual health systems that have $20 billion of net patient revenue under management. What really powers our success with our customers is really two things. It's our culture and being a top place to work, along with best practice operational processes, as evidenced by our MAP awards and our peer review status with HFMA. And probably most importantly is the partnership and the collaboration that we have with our customers, such as Nicholas. I'll turn the call over to Matt to share a little bit about Nicholas Children's Hospital.
Thank you, Judson. I'll start by sharing a little bit about the organization as well. We are located down here in sunny Miami, Florida, and we recently celebrated our 70 years of taking care of children. As mentioned earlier, we are South Florida's only healthcare system exclusively dedicated to taking care of children. We have 309 beds with over 15 comprehensive outpatient centers across our counties, our 4 counties that we primarily serve. We have over 800 physicians on our medical staff, with almost 500 of them being pediatric subspecialists and specialists. In a normal year, we would normally see about 450,000 kids walk through our doors in our various locations. We are routinely ranked among the best by U.S. News World Report. And I think it's important to note that our partnership, and we use that word very deliberately, our partnership with Ensemble started in late 2019. So we're relatively young in our partnership experiences. As I look back through the last year, really through the lens of the pandemic that all of us, all hospitals have experienced, I do want to share a couple of the unique challenges faced by children's hospitals, both pre-COVID and post-COVID environment. First of all, pre-COVID. Unlike adult hospitals, where the payer mix can be more commercial and Medicare, at Nicholas Children's and at most other freestanding children's hospitals across the country, we have a very high reliance on Medicaid. In many children's hospitals, it's more than 50% of the payer mix. For us, here in South Florida, it's closer to 70%. Yes, 7 out of 10 of our patients are covered by Medicaid. I never would have missed the days of Medicare insurance, but definitely different with the Medicaid business. And here in Florida, it's mainly Medicaid managed care, which comes with its own additional issues, such as increased paperwork, pre-certification and authorization processes, increased denials, and appeals that are needed. Given our payer mix, we have to focus on being efficient, getting reimbursed for every dollar, every penny that is due to us, and we also have to rely on philanthropy to also help close the gap in our shortfall. In addition to our payer mix, children's hospitals also have a tendency to have more unique populations. Our patients range from lower acuity patients that are walking through our doors all the way to very high acuity, very complex patients. Those with many complications that children live with and eventually transition to adulthood. A couple examples: cystic fibrosis, spina bifida, etc. One example really comes to my mind. It's a little girl who had a major deformity of her spine. Visualize this. Her spine that was in the shape of a V pointing outwards. After many surgeries and therapies, she's now dancing on TikTok. Right? So this is just one example of the unique patients that we serve. And many of our patients also have extended length of stays in the hospital, many over 30 days, and more than a few that stay over a year. The last thing on children's hospitals, we work with the parents that are very worried, right? So we probably all have parents and brothers and sisters that have accessed healthcare in the adult world, and some of us even have children. So how we communicate, how we interact with parents that are worried also requires a special skill set that children's hospitals have. So now we think about the pandemic that just started about a year ago, right? And what it did to children's hospitals. Many people think of the pandemic and the impact that it had on hospitals as an adult event, right? But there was also an impact on children's hospitals. For children's hospitals in many places, we offered ourselves up as backups to the adult counterparts in the height of the pandemic. Children's hospitals also saw the negative impact of shutting down elective cases, just like the adult hospitals did. We also had to gear up the use of personal protective equipment and other supplies, very similar to like our adult counterparts did. And lastly, unlike the adult hospitals, where there were significant visitor restrictions, many children's hospitals tried to limit our visitors, but also respecting the patient and family-centric philosophies. So for us, as we take a look at Nicholas Children's in terms of the rapid decline in patient volumes, you'll see across these three graphs, admissions, observations, and inpatient surgeries, a severe decline in the April timeframe when the elective surgeries, elective procedures were put on hold. You'll see a gradual increase in volumes as we look across most of those indicators throughout the year. But you will notice, unlike some of the adult hospitals, which we'll see here on another slide, our transition, our increase, we have not yet achieved back to pre-COVID pandemic volumes.
I think, Matt, to your point here, we were very interested in understanding the volume and essentially the return to pre-COVID volumes of children's hospitals compared to adult acute hospitals. And as Matt pointed out, children's hospitals had the same issues related to increased costs around PPE, increased costs related to staffing, increased concern around the visitors' policies, and we were interested in the correlation. So what you see here on this chart is that adult acute hospitals have come close to returning to pre-COVID volumes. What you see here also is how Nicholas's volumes have trended. And so you can see here that although acute adult hospitals have returned to around 98% of pre-COVID volume, Nicholas is at 72% of pre-COVID levels, which we believe is pretty consistent with other freestanding children's hospitals in the country.
Yes, thank you, Judson. And that is very consistent. When I talk to my peer groups, very consistent in terms of the gradual recovery of inpatient volumes. The biggest challenge to children's hospitals continues to be really the ED and urgent care visits, which, again, across the country continue to be down about 40% or so. So as we take a look at the COVID-19 impact on the environment, on our current environment, a couple thoughts here, right? The first is overall, children's hospitals had less federal relief than our adult counterparts. Specifically, there was no hotspot funding that made it to the children's hospitals. If you recall, this really was around a majority of patients, a significant number of patients that had COVID diagnosis. There were some additional reimbursements that were provided on a discharge basis for those hospitals across the country. As we all know, at this point, COVID-19 has not been a pediatric event in itself. Thank goodness. The biggest impact has been on adults and on the elderly, unfortunately. For children's hospitals and for Nicholas Children's and specifically, again, we had to ramp up costs, as Judson mentioned earlier, in terms of screening and testing, just like everybody else did in the industry. We had to provide PPE to protect our hospital staff, patients, and families, physicians, et cetera. And imagine this in terms of patients coming through the door and bringing two parents, right? So not only did we have to worry about the patient, because they could be potential carriers of the virus, we also had two visitors that came in with every single patient. That really refers to the last bullet point here in terms of how do we make sure that we maintained our patient and family-centered visitor policies. I will just share with you from a personal standpoint, when my daughter, albeit she's 20 now, went into the ED, I was not allowed in the waiting room. I can't imagine doing that in a pediatric environment and would not do that here at this hospital under any circumstances. So how do we respond to that? How do we make sure that our staff and our visitors, our families are protected with some of the cost increases that we had to deal with specifically? So now we shift over to combating the disruptors. I think Judson and I will take this one together as we take a look at the partnership between the two organizations, right? So for us at Nicholas, it was really around how do we get the resources that are on the leading edge, on the bleeding edge of revenue cycle. How do we find the best partner in the industry in order to help serve our patients on a go-forward basis? Really around a new approach, right? So as much as we wanted to be one step ahead of managed care companies, we found ourselves always being one or two steps behind. And so how do we get that new approach with a revenue cycle partner that really adds value to the organization and to the children and families of Southeast Florida here? We also wanted to make sure that there was mutual success and that we were going in the same direction with common goals.
And I would add to Matt's point, when you think about the uniquenesses of children's hospitals, but also kind of the fundamental requirement that revenue cycle operate at a very high efficiency, this is kind of a use case and a kind of a white paper on why a highly efficient revenue cycle is not only critical for a children's hospital, but think about this. So 70+% of the payer mix is Medicaid. And then you think about during COVID, adult acute facilities were receiving a 20% add-on payment. Well, there was no such thing for children's hospitals because the volume was not COVID related. But Matt and his team had the increased operational expense of PPE, drugs, those types of things that were not being offset by that add-on payment that adult acute hospitals. And with 70% Medicaid, you have levers to pull, and specifically managed Medicaid. So in acute environments and also other environments that have different payer mix, you have other levers to pull to offset increased costs, which would be you could pull the charge master lever by raising prices. You could renegotiate contracts. You can drive volume. There are a lot more levers in an environment in which is not 70% Medicaid, managed Medicaid as well, but also the fact that during COVID, there were no add-on payments. And so when you kind of boil it down, what were we focused on? And the need to ensure that there was a high-functioning revenue cycle was not just kind of a need or a wish. It was actually a requirement when you think about the razor-thin operating margins and or losses that children's hospitals operate under. And so, one, the need for a highly functioning revenue cycle was important, but also the speed to value, which is super important. So Matt and I shared that we started our partnership at the very end of 2019. And then obviously first quarter of 2020, we began with COVID. And so the task here was, how do you quickly implement technology processes in order to get an efficient RCM operation, not only in a pretty aggressive time frame, but during COVID. And that's exactly what we did. So the way that we went about this is overlaying our business intelligence tool, which is called Ensemble IQ, on top of all of Nicholas's existing technology. So we weren't interested in kind of ripping and replacing the things that they had already purchased and were using, and we were interested in causing the least amount of disruption, but getting the greatest amount of benefit and yield. And so I won't walk you through the technology here, but the technology was designed to sit on top of their existing EMR and their existing function, but also to identify the gaps and to squeeze out additional yield and efficiency. This next slide kind of breaks down where the areas that we were looking to get efficiency and yield from out of a children's hospital. And so these numbers kind of work in the process of not only children's hospitals, but acute hospitals as well. And so you can see here, we're looking to get 50 basis points of net patient revenue improvement around virtual utilization review, accurate physician advisory, 100 basis points in charge capture, using our DRG validation tool and analytics and AI here, improving the accuracy of coding. Matt talked a little bit earlier about denials and appeal. So with 70% Medicaid, managed Medicaid, payer mix, the importance of getting, one, the UR part right, and then two, being prepared to appeal and fight denials is really important. Another 80 basis points in identifying contractual underpayments, and then improving the efficiency which we were liquidating the accounts receivable, ensuring that we were also being productive through our use of technology, including automated bots and AI technology here. So you kind of add all these things up, and these are the things that we were focused on doing for Nicholas in a very short period of time, least amount of disruption, and aligning to their cultural and mission of the health system.
Right, Justin,
and then what did that?
I would just add one point as you continue on to the next slide. It was really also around pace, right? So recognizing the need to move quickly in a normal environment is what I think everyone is moving towards. But in an environment where almost overnight the business volumes deteriorated substantially. And so the ability to react and to implement quickly was a underlying key theme, I think, between our two organizations.
Yeah, absolutely. And I would say, that can't be underestimated. The alignment of the two organizations and the support from everything from IT to clinical alignment to operational and business alignment, that is part of the success here, is bringing the teams together, understanding the time frame that we were operating under, and more importantly than the time frame, the purpose and the reason for which we were moving so fast, and that was to help the health system, right? And I think when we're all working for common purpose, and it's more than meeting deadlines, it's because it has a benefit to the health system and the community. This is a little bit of a snapshot of kind of this transformational process that we went through. As I mentioned to you, we were very interested in not ripping or replacing technology, but overlaying our technology in order to provide the most benefit. But technology is just that, right? You implement new technology, you also have to be able to change the processes and the procedures to support a highly functioned revenue cycle. Everything from how we verify insurance and communicate and digitally communicate with patients, all the way to what do you ultimately do when the claim is paid. And so a lot of credit here goes to Matt and his team for helping us implement more than 100 new policies and more than 300 standard operating procedures in order to transform the revenue cycle here at Nicholas. And below are kind of the shots of the areas front, middle, and back that you can see. These were prioritized about the areas that would provide the most net patient revenue lift, the areas that would improve the most of the balance sheet, and those that were patient-facing and an impact to the patient experience. And so you can see here significant amount of achievement from the teams, Matt's team and our team, on getting to this point. Matt, anything to add here?
No, I think, you covered it.
Great. And then part of that, and I'll let Matt speak to this, but part of, as any, whether it's acute, adult, or children's hospital, is part of one of the things that we want to do in RCM is challenge the status quo. Denials that were previously written off. Why? Why aren't we arguing with the payer around what's appropriate and defending our position? And so we really wanted to take a look at different things that were impacting the revenue cycle, the P&L, and the balance sheet. And Matt will share with you one of the examples that we looked at, and on face value, most people would have probably given up and said, let's just move on to the next thing.
Yeah, so a very specific example in terms of being able to work together across the organizations, but more importantly, across the entire state. So as part of our the way we operated as a state was around interim billing. So many of you are probably familiar with, on the Medicare side, interim billing, interim payments every 30 days. In the state of Florida, prior to earlier this year, there was no interim billing on Medicaid patients, Medicaid traditional or Medicaid managed care patients. And so as I referred earlier around the number of patients who stay in our organization for long periods of time, it was a financial burden on the organizations. And so working together collaboratively with Ensemble, as well as the other children's hospitals across the state of Florida, and with the secretary, ACA secretary here in the state of Florida, being able to work through changes that were needed in order to make some adjustments in terms of interim billing. So as we take a look at it for us, real live examples around over the last year, we had 27 patients who stayed more than 1 month, right? We had 2 patients that were here greater than a year, and many patients between the 3 months and the year time period. All of this resulted in funds being tied up and not paid to us in a timely manner related to that interim billing. Again, another real life example where we're sitting here today, where we have a little girl who's in the hospital today. I think she's celebrating her 20th month with us since she was born, right? So it's never gone home, and we are her family, right? The nurses and the caregivers on the floor are really all she's ever known. Up until these changes, we would not have been paid for those services provided until she gets discharged. Underneath this new scenario, we will get paid on an interim basis to help us cover some of those costs. From a magnitude perspective, we're talking tens of millions of dollars in interim payments as a result of this change.
And I would, to Matt's point, this required a high level of collaboration between not only and Matt and his team get the credit for driving that among other children's hospitals in the area, but working collaboratively with the legislatures and the folks in the government to say this is why it's important. And I think that is really where the teamwork really came to play, is where, as an RCM provider, we can't change the regulations, but we could certainly provide insights as to how many patients were impacted, and then also what was the impact on the health system, and then how did that compare to other states and what they were doing. And so a really good outcome here that Matt and his team get the credit for spearheading. And as I mentioned earlier in the call, one of the challenges, and I remember when Matt and the board selected Ensemble as their partner, everybody wants to know, well, how quickly will I begin to see results of this new RCM partnership? And then you can imagine with COVID, people were anticipating delays in that. And what I'm happy to report is not only did we not see delays in how quickly we materialized results, but that actually was at or above plan. And so on this page, what you'll see here are 2 charts. One is kind of the pre-baseline of cash collections prior Ensemble, and then quarter-by-quarter performance post our engagement. And what's interesting here is most people believe that these types of transitions to an RCM partner may cause cash disruption. And what you'll see here is that's not the case, that Q1 cash comes out at 101.5% or higher. On the bottom really is what we call speed to value, and how quickly are you finding items that put money to the income statement and the balance sheet. And so here what you'll see here is improvement in net patient revenue by quarter, and this is really just kind of the proof in the pudding to say a transformational revenue cycle process doesn't have to be a year-long consulting project in which you don't begin to see results until day 366 or 356. You can begin to see results in each quarter. Now, what we do here is we take this playbook that identifies areas that will impact balance sheet, income statement, net revenue, and also patient experience, and we then prioritize these things. And we say, okay, which ones take 3 months to do, and then which ones take a month. And so what you see here is kind of some building blocks that ensure that value starts to being accretive immediately in Q1 with the things that can begin to flow to the P&L and to the balance sheet. And then you say, well, what does all that result in for Nicholas? And what you can see here is over a $20 million net lift, which is 4.3% of their net patient revenue. And you can kind of work across the compendium here and see cash collections 102.5%, $30 million recovered in aged AR, and so on and so forth. I won't go through each one of these things, but it is part of this comprehensive playbook that we deploy to ensure that you get immediate value and that it's aligning with the mission and the objective of the health system. And a lot of this credit of these results go to Matt his team for their not only support of this, but vision to see that things needed to change in order to produce a better benefit.
So I get asked the question, a lot around, well, what were the results, right? What's the real impact on the organization and the patients and families that we serve? Judson kind of went through, some of the numbers, and I think they really speak for themselves. But for us as an organization, there's more to it than just the numbers, right? It really is partnering with someone that allows us to achieve, the results that we've achieved thus far, but for the reasons of reinvesting back into the organization, investing in high-quality care, right, specialized care. And so when I talk to our folks here, it is all around this revenue lift and this importance really allowed us to reinvest back into raises last year. Investments in surgical services and updating OR rooms, OR equipment that are very much needed, and really to drive the patient experience, for families when it's needed the most, right? No one wants to necessarily come into a hospital, and coming in during a pandemic is even more challenging. So reinvesting and being able to get things back to our community was one of our key focuses. And so really, this partnership really has allowed us to kind of weather the COVID storm as best as we can in order to come back to our mission, right? Really is around inspiring hope and promote the lifelong health, providing the best care to every child, and being able to do that in the best way possible. So with that, Judson, I don't know if you have any final thoughts before we kind of go over to the Q&A.
Yeah, no, Matt, thank you very much. I think it would be remiss of me not to thank not only you and your team, but Dawn and Ariana and everybody who has kind of really made this a true success story. So thank you for sharing the story, Matt, but also thank you and your team for all you've done to make it a successful partnership.
Thank you so much, Judson and Matthew, for that fantastic presentation. And we will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for today. And we've already had a few questions come through during the presentation, so we'll go ahead and get started with those now. And the first question is, when do you anticipate children's hospitals' volumes will recover to the level of acute hospitals?
That's something that we ask ourselves every day, myself and my peers as well. When we take a look at it, there were really three reasons why volumes deteriorated in the pediatric space. One was, they weren't outside getting bumps and bruises. All the sports activities were canceled. Number one. Number two, call it the respiratory or the infectious disease part of things, flu, RSV, et cetera, really non-existent because kids weren't in school and everyone's wearing masks, right? And then the third one was really around the fear of patients and families coming to the organization. I think that one has pretty much been solved in terms of the communication, the education, being transparent to our communities that we serve. I don't believe folks are afraid to come into the hospital anymore. It's really the first two. So the answer really becomes around when life becomes, more normal, right? When do kids start playing again? When does everyone get back to school? Those types of activities is really the kind of the driving factor behind it. I think most cases, optimistically, sometime later this year is when we're planning for it in terms of the volumes coming back, but also preparing that it may take a little longer.
Thank you so much. And we've had another question come through, and this person wants to know, why is it important for a children's hospital to find a partner who not only has the expertise needed to lift revenue, but one that also shares your mission?
What I would start by saying, I think it's more not necessarily around the lift in revenue, although that is important, specifically in times when we're going through a pandemic. But it really is around a partnership or a partner that shares the mission, right? Because I've been doing this for quite some time now, and it is really around having a partner that's sitting at the table with you, all right? And we choose those words carefully. It's not across from the table, right? So when we talk about partnerships, specifically the Ensemble partnership, it really is we're sitting at the same table, right? And knowing why we do what we do in terms of the mission of the organization, taking care of children and their families, and connecting that back to the folks that send out the bills and collect, right? It's an important piece. It's not just a vendor relationship and chasing it. They're still our patients, and our mission and how we do it is absolutely important to us. So to me, it's more around that partnership that can connect back to the mission. And when we take a look at Ensemble, part of the early conversation was absolutely that. This is truly a partnership between two organizations with like missions.
And I think that's
so
also
much,
really part. Yeah, maybe I'll just add there. I think it's part of what goes into the pre-planning of a relationship, right? Understanding what's important to our organization, because many people could say, hey, the dials you're going to turn, we'll take point of service, for example. Well, you can get more cash and improve net patient revenue by turning the dial aggressively on point of service. But it's a children's hospital, and it has a children's hospital with a mission. And so that's not a dial you're going to turn to crank out revenue. Or another dial that you may not turn is relationships with physicians or how you handle collections and those types of things. So I think that's really important when you begin these partnerships, to really say, what are you trying to achieve, what aligns with your mission, and what doesn't, because that type of misalignment can be devastating, not only for a relationship, but for the patients and others that are involved.
Thank you both so much. And it sounds like the most important thing coming from this partnership between your organizations is just connecting everything back to the mission and just how important that is for the patient, for the hospital, for everyone involved. We've had several more questions come through, so we'll go ahead and start working through those. The next person wants to know, what did your original assessment predict in terms of NPR lift? The results thus far are amazing.
So I think generally our ranges range from anywhere between 2 to 5% across the board between acute, adult, and then children's hospitals, pretty consistent. I would say our original estimates were less than where they are today. I think Matt, if I recall, they were in the 2.5% to 3% range, if I recall correctly.
Yeah, that's correct, Judson.
Thank you both. And the next question that came through is for you, Matt. And this person wants to know, has any of the collaboration over the last 18 months assisted with your organization's payer mix?
Yeah, so the short answer is yes. We have seen a slight change in payer mix to a little more commercial. I think it's a good question, but I think our payer mix really represents the overall component within the state of Florida, and so I talk to my board a lot around payer mix, and so how do we change it? How do we drive those changes in terms of being in different locations, opening up services, et cetera. But I think it's also important to understand that the overall pediatric mix across the organization and across the different counties, changing that dial by 10, 20 percentage points is impossible to do. And so how do we work in a world, in an environment that leverages expertise, knowledge, et cetera, in the Medicaid world, but also going after the commercial mix at the same time? It's a two-pathway, multi-pronged approach. It's not one or the other.
Thank you so much. And our next question that's coming through is this person's wanting to know, is this evaluation by Ensemble only on a health system level, or could it be used on a departmental or divisional level as well?
Typically, our assessments are on kind of end-to-end throughout a health system. And the reason for that is that if we think about revenue cycle, there's an interdependency on pretty much every segment of revenue cycle. So typically, we want to do it end-to-end. We may end up only helping and assisting a provider on a particular function of that, but understanding how one area is being impacted by upstream areas is super important and helps paint the larger picture of not only the codependency, but also how each area plays a part in the solution.
Thanks for clarifying that. The next question for you both is, does Ensemble provide education for the revenue cycle team at Nicholas Children's Hospital?
So I'll take that first.
Yeah, go ahead, Matt. Yeah, go ahead.
Yeah, the answer is yes. It's really an integrated approach, and I think the real question, or real answer is not necessary for the revenue cycle team, but to the operators, right? How do we fix things up front before they happen, negative or bad things happen, and I believe that really happens at the operations level. So it's the person who's entering the charges or scanning the X, Y, or Z or scheduling the patient. All of that is well coordinated and a ton of education across the entire organization.
Yeah, and to Matt's point, that codependence that we talked about earlier is very much part of, like, clinicians are there to take care of patients. But the reality is the buttons they click and the things they document have an impact on how the health system is paid. But it's not their primary responsibility. And so part of our role as RCM is to ensure that we're providing them feedback, guidance, education in a way that's digestible to them and also understands and values their time. Talking with a nurse manager around CPTs and HCPCS is not what they went to school with, and quite frankly is not what they should be focused on. But giving them tools and resources and education that allows us to have that conversation, but understanding kind of where their time should be spent and taking away all those extra layers of work that we sometimes impose upon them is really important. And so, yes, that education, but really it's education and collaboration with those other areas of the revenue cycle team and those upstream departments that we're so dependent upon to get it right, whether it's case management or physician documentation, ancillary departments. That's really key and is part of our success.
Thank you, Judson and Matt, for your, expanding on that for us. The next question we have is, do you see other children's hospitals trying to tackle the issue of no interim billing with other state legislators or Medicaid billing? You mentioned this was an interim fix, but will this be pushed into a long-term reality?
Yeah, so my apologies if it came across as an interim fix. It's actually a permanent fix that was put into place on February 1st, I believe. And the great news about this is it applies to every hospital in the state of Florida. So this was not specific to the Nicholas or the Children's Hospitals, but everybody should be getting the same benefit along those lines as of February 1st. But it is a permanent fix.
And I would say here in other, yeah, and I would add maybe in other states, interim billing is just one component of it. What's really important is when you think about there are also multiple payers that have different requirements in every state. One of the things that we try to do as Ensemble, as a partner to our clients, is to lay out what all those requirements are, and then compare and contrast not only the requirements but the payer behaviors state by state by state. And quite often we'll see that a single payer that is nationwide may be applying policies and procedures to one area of a provider universe in a particular state or a particular market and not in another. So really kind of not only understanding the state requirements, i.e. interim billing, and seeing how you can work with the state on that, but also the same way in a managed care environment, which is comparing and then also challenging some of those managed care behaviors.
Thank you both so much. And the next question we had come through is this person's wanting to know what role did Nicholas Children's Hospital play in establishing interim payments from MCOs in Florida?
So we were one of the organizations that first took the lead with ACA and the legislators up in Tallahassee. But it really was a collaborative effort around a lot of the other three children's hospitals, the other three freestanding children's hospitals in the state of Florida, providing data behind the scenes, and then of course for us, Ensemble, being able to quantify that impact, and us being able to sit at the table and share the stories and the dollar amounts of what this meant. So it was really us leading that effort in terms of a collaborative approach across the state with then Secretary Mayhew and others in Tallahassee.
Thank you so much. And the next question, this person wants to know, they're just curious to know if you've had to adjust your strategy or policies around the patient balance portion due to COVID financial impacts. With only 30% or so of your patients having a patient balance, those that have high deductible health plans become a big chunk of needed reimbursement. Have you had to adapt?
The short answer is no. It was really around, and Judson can provide some additional commentary around implementing best practices, regardless of the pandemic and whatnot. But it was really around the point of service, collections, past due amounts, other previous visits, et cetera. But our ability to implement best practices really is what we had focused on both pre-pandemic and during the pandemic.
Thank you so much. And the next question we have time for at least a few more questions here. This person wants to know, have the managed care companies been receptive to the changes Ensemble has made to your revenue cycle?
So the short answer is yes. We're able, and the reason it's yes, for the most part. I mean, of course, changes are always difficult, especially when you start thinking about some of the larger payers. But it's because we go with data, right? So this isn't necessarily about going in and saying, well, this one case was X, Y, or Z. We go in and say, no, this has happened now 10 times, and these are the changes that we're making because of those components. Leveraging that expertise around what's allowed versus not allowed was the other component. So the changes that we've done thus far are really consistent with, again, best practices, but also with the provider or payer manuals that we operate by. But we couldn't do it without the data and some of the individual cases that we're able to take forward. For example, through joint operating committees, right? That's where we sit at the table or across the table, and in some of these cases, with our rev cycle folks, with clinicians, with managed care folks, and the payer. Those types of things of putting those into use has been really substantially significant to us.
Thank you so much for walking us through that and providing such a good explanation of the whole process there. It looks like we have time for one more question today, and this person wants to know, can you speak to any changes from a patient experience perspective stemming from the partnership? They really, they said it was great to hear about your alignment and missions.
Yes, I would say, and Judson, please provide your thoughts on it too. But
yep.
to me, around the patient experience, a lot with the scheduling and the front end side of things, right? And so having the right resources, the right technology, the right amount of resources around how long does it take to answer the phone, as an example. And I know that prior to our partnership, we had some areas of improvement in there. And so now with the tools and technology in place, being able to measure and monitor and manage that, we have seen good improvement and good changes in those areas related to patient wait time on the phone, for example.
I think also as much as an industry we're focused on digital engagement and scheduling and, as Matt mentioned, getting down wait times and all of those things, which are really important, and we're focused on that. There also has to be something for just purely making sure that the billing experience is accurate. And patients come, they have a great clinical experience. What we see far too often is that clinical experience is then kind of smudged by the billing experience. And so just ensuring that we're pre-sorting things accurately, that the bills are accurate and clean, and they're not getting, kind of random bills for things that they weren't expecting and are inaccurate, and denials from the payers and all of those things. So really, to Matt's point, yes, we're working on hold times and authorizations and clinical availability of resources for appointments, but also have worked a great deal to make sure, one, the bills we're sending out are accurate, timely, and that they offer kind of clear visibility to the patient versus getting a bunch of stuff in the mail, not knowing what's coming. So something to be said for just making sure the bills are right.
Thank you so much, Matt and Judson. And it looks like it's almost time to wrap things up today, but I want to ask before we do, if either of you have any final thoughts to share with everyone today.
I would just say, I want to, thank Judson and the team from Ensemble, for really helping us through, a difficult time with the pandemic. The pandemic and COVID really, in my mind, helped accelerate some of these changes that are needed from a revenue cycle and operations perspective. But the key on this, in my mind, is really around aligning missions and connecting the dots back to the patients that we serve. One of the things that I'm very proud of is that we have not lost that in any type of, through the pandemic or through this partnership around, the importance of taking care of kids and patients and families first is really the underlying mission that we have here. And being able to find someone that believes in that and demonstrates it, I think is a key component to us. At the end of the day, these patients come to Nicholas Children's for great care. And we have the utmost privilege and responsibility to do that regardless of how we do it in the background.
Matt, I couldn't have said it any better, so thank you.
Well, that is all the time that we have for today. I want to once again thank Judson and Matt for their excellent presentation today. And I also want to thank Ensemble Health Partners for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.